sounds pretty dry. Why should I care? And I'm going to give you some information why you should care. So let's go forward and ask ourselves the first question. It isn't always about disruption of vascular calcium. It's about how do we do that and keep the vessel preserved to minimize the vascular injury. And if you're asking yourself, if you're designing the perfect calcium modification tool, what should it be? Well, firstly, it should be specific to calcium. And that means when you apply force, it's orientated towards the target. And it's only orientated to the targets. So there's no point in applying force to the normal vascular tissue where you don't need to disrupt the calcium. If you add 1 and 2, what you get is a low risk of complications. So you want your device to be efficacious and you want it to be safe. So the questions I'm going to pose today are, first of all, can a shockwave be used safely? How do shockwaves impact coronary calcium? And assuming that they do, how do we optimize use? So the first precept that we start with is what is a shockwave and how can we change it to maximize efficiencies? And shockwaves are just a form of acoustic waves. So everybody knows a sound wave. There's an approximation of the sound wave. You can change the frequency of the sound wave to make it go faster or slower. And what a shockwave is a very intense, powerful wave with a very high peak and a low negative waveform that creates this sudden pressure. And we've known about this for a long time. We've used it to modify kidney stones, for example. And we know that this, when it's applied outside the body, it can fracture the kidney stones, it can put them into smaller little pieces of calcium, and they can be passed safely out of the body. But we also know that this high energy acoustic pulse contains this compression phase, and that's most of the effects in terms of shockwave are compression effects. But the extracorporeal shockwave also has this low negative pressure waveform, and that causes what's called tensile phase. And the easiest way to think of that is like pulling forces. And you really don't want pulling forces when there's vascular tissue, because you can create rending or shearing between the tissue. And that, can, of course, can lead to damage. So if we understand this is effective, how do we make it safe? Well, we're doing that. The first thing is that, of course, with a kidney, it's a long way away. So with a vascular tissue, we actually have the percutaneous way of delivering therapy inside the artery. And therefore, we don't need anywhere near as much force to get the same effect. It's just millimeters instead of centimeters. So first of all, we reduce the force. And you can see that there, that the force is now 5 megapascals instead of 10 megapascals. But we've also done something slightly different, and that's where the safety comes from. So we've retained the efficacy. That's the high amplitude, short duration waveform, compressive stress. And we've minimized this tensile waveform, this negative pressure waveform, to minimize soft tissue injury. And if you're going to take away anything from the MOA, it's that it's selective for calcium, and it's selective because of the speed that sound waves or shock waves travel through different types of material. So the material determines the effect, and I'll give you an example of that. So you've got your balloon on the left, schematic, soft tissue, and then calcium. There's really no difference in terms of something called acoustic impedance between the balloon and the soft tissue, but calcium, by contrast, has got very high acoustic impedance. So that means that the energy is transferred to the calcium rather than transmitted through the calcium. And that energy, that compressive stress, causes disruption of the calcium, and you get roughly about 80% transferred to the calcium, and about 20% is reflected. And again, a critical point that these disruptive forces only happen when the shock waves encounter changes in acoustic impedance. And that makes it very selective. That matters most when you have normal tissue on one side, and of course the shock waves just pass harmlessly through because there's no changes in impedance. And if you compare that to the other side, by contrast, you get disruptive forces because of the change in impedance. And you might say, well, okay, but does it work on eccentric calcium? And it works, it's more important in eccentric calcium because of the risk of vascular injury. And that's shown in this cadaveric study, in which you can see that in terms of fractures, it was a little bit more effective than cutting balloons and high pressure balloons, but it's really in terms of injury that it mattered most. Almost no vascular injury compared to the cutting balloon or the ultra high pressure balloon. And you can see that in eccentric calcium. When you looked at it, first of all, you can see that the fractures are there. These are past slides. The fractures are there. On the left, it's IVL. On the right, it's high pressure inflation. You can see the fractures. But unfortunately, you can also see that there's significant disruption with the high pressure balloon, and there's no damage at all with IVL. And this matters most in eccentric calcium, which of course is the commonest forms of calcium. And even within this study, there was no disruption of calcium seen at all with either cutting balloons or OPNs. And that's because the force is delivered to the elastic side of the vessel. So you can see the calcium outlined there, but unfortunately you can also see these intimal tears, which is what happens because of the physics of it. And that explains why the safety profile is so good, and that's been over quite a number of studies in patients now. And that leaves us with the final question, so how do we optimize use? And that's down to the field effect. And the field effect of IVL is highest perpendicular to the emitters. So if you've got a lump of calcium or a nodule or what have you, you want to align the emitters with the calcium, because that's when you get the maximum effect. There is a kind of summation effect in the middle, but the maximum effect is perpendicular to the emitters. My time is up. That actually looks like one of my slides, so I'm happy enough with that. Happy to take any questions.
Thank you, James.